Welcome back, and I hope you're prepared for our next very informative session. A warm welcome to our chair, Dr. Ahmed Al-Mazmi, American Board Certified Consultant Neonatologist, Sheikh Shahbood Medical City, Abu Dhabi. Please give him a round of applause. Doctor, the session is yours. You will sit there and...
Am I going to introduce them?
You will sit there.
All right. Good morning, everybody. I hope you had your coffee and are refreshed currently to listen in to our next talk. So this session, we're going to start with an excellent talk by Dr. Khalid Al-Atawi. Dr. Khalid is a consultant neonatologist and a clinical quality specialist at Latifa Hospital in Dubai. He is also an assistant professor of pediatrics at the Dubai Medical College. He's going to talk to us about the impact of developmental care on premature infant outcomes. Please join me in welcoming Dr. Khalid Al-Atawi.
Bismillah ar-Rahman ar-Rahim. First, I would like to thank my dearest brothers and colleague, Dr. Ayman and Dr. Junaid, and the organizing committee for inviting me for this prestigious conference. Thank you, Mr. Chairman, for introducing me. Today, I'll be giving a talk about the... No, this is not... Okay. Yeah, the second one. Yeah. Okay.
There we go.
So I have nothing to disclose. I work in Latifa Hospital. It is a tertiary center in Dubai. We are having around 5,000 delivery with more than 800 admissions per year. We are now 74-bedded unit after merging with Al Jalila Hospital. We are having out of those deliveries, we are having 25% admissions preterm, 70% are late preterm babies. We deal with babies as low as 420, and today we are expecting 370 grams, 25 weekers. According to Vermont Oxford Network, we are level 4 because our adjacent hospital, Al Jalila, is having the ECMO. So this is my objectives, and I will start by a question. What is the difference between the adult brain and newborn brain? Of course, as you can see here, that the newborn brain is increasing in size starting from the 22nd weeks onwards, and the rate of cortical development will start increasing. The brain is smaller in size in the preterm babies. The more the preterm, the smaller the size, thinner cranial skull, small arachnoid space, underdeveloped, and most important is those preterm babies are having very basic electrical activities in the primary sensory region where the touch, vision, and hearing are processed. Also, another important point is that the dendritic arborization and synaptogenesis and myelination is developed after the 26 weekers onwards, as you can see in this slide. You can see the difference between the brain at the 26 weekers and the brain of term baby. How much is the difference in the dendritization and the brain tissue itself? So what are the challenges related to the brain of preterm babies? They are at risk for neuronal injury due to their condition, their diseases, their possible complication, and the treatment that we are giving. So it is difficult to assess their neurological function due to their condition and if we are giving the sedation at any time. And what is our aim is to prevent the neuronal injury. We need to prevent any disturbance to the brain metabolism and the hemodynamics of those tiny babies. So what are other challenges that we are facing? Those preterm babies, whenever they are admitted to the NICUs, they are having possibilities for hemodynamic instability, neurological morbidities in the NICU, hypoxic ischemic encephalopathy, IVH with different grading, post-hemorrhagic hydrocephalus, necrotizing enterocolitis, complex respiratory problems, and morbidities associated with the treatment. In the late 1980s, Dr. Heidel C. Als developed the NIDCAP, or the Neurological Developmental Care and Assessment Program. And this is the most well-known formal approach to developmental care in the newborn. So what is our aim behind this care? It is mimicking the in utero environment to simulate and promote the normal neonatal growth in utero for those who have been born prematurely. And again, Jenny Staiv, which is a registered nurse, stated same statement. In order to promote the stable, well-organized component infant as possible, then we need to have an environmental customized care mimicking the in utero care. So all the NICU care is a brain care, and this is the role of the caregivers as who are the key instrument for this care. So one brain for life is the slogan from Heidel Als. We should know that the incidence of preterm babies is big, reaching up to 12.7% in states. 4 million live births, out of them 520 are premature babies. So we need to know what some of the basics that the CNS maturation that occurs in utero and the fetus is protected from the pain. From the pain, from the light, from the sounds, and the movement, and a sudden change of the gravity-imposed positions. For those premature babies, we can have, after birth, we can give them some stressors, and this is due to the setup of the place. Many caregivers and the changing of the caregivers, the unpredictable schedule based on the caregiver's convenience, the care and procedure itself, and the mechanical challenges such as the procedures, the endotracheal intubation, intravenous catheter insertion, monitor leads, all this are points to be tackled. So the philosophy behind this NIDCAP, or the technology for the developmental care to protect our newborn babies, is based on 2 points. The first is the attention and responsiveness towards the limitation that the immature central nervous system of preterm babies is lacking, and attention and responsiveness for the behavioral and physiological cues for the baby after the birth, where all the caregivers will have a hands or a point in the development of such a problem. So our aim is to have a developmental care mimicking the in utero care. And this is, can be summarized in this slide, giving energy conservation for the growth and the maturation of by providing a minimal handling, prevention of the pain, fatigue, stress responsiveness due to the hypothermia invasive procedures, reduction in the environmental noise and the light, optimal positioning, and provisioning of the appropriate developmental care which will be tolerated by the sensory input on the baby. How we can affect the sensory input? Yes, we can affect the sensory input of the baby in 2 ways, whether intentionally or unintentionally, and this will affect the influence on the long-term development, and also the lack of sleep and lack of sleep cycle maturation is very important and will cause a negative effect on the CNS development. So how we improve the preterm infant outcome, this is one of our aim. Also, we should improve the physiological function of our baby. We should improve the feeding behavior and the weight gain of the baby. And by providing this, we will lead to decrease in the length of hospital stay, and we will improve the neurophysiological outcome of the brain of the preterm baby. Now, what is the implication of this? It is not only ensuring the survival. This is not enough. This is not our aim. So what is our aim? Our aim is to improve the quality of life of our preterm babies. Why? Because we might have outcomes, bad outcomes, starting from cerebral palsy, hydrocephalus, microcephaly, and blindness, deafness, and seizures that will lead later on to poor school performance, lower IQ score, and behavioral problems. To understand this infant behaviors, we should know that we are having 5 stressors or 5 factors. Mainly it is the motor factor that we look for, the motor tone of the baby, the movement and the activity. And this will help us through watching and observing the agitating waving movement of the baby and the holding of the fingers and the hyperextension of the extremities. So those are 3 main points in the motor part of the neurodevelopmental care. We are having the autonomic, which is can be obvious by the color changes, the change in the vital signs, the visceral response such as vomiting, hiccups or passing the gas, sneezing and yawning. We are having the state, and this is the state of arousal, whether it is quiet sleep, active sleep, or drowsy. And the most important is the quiet alert state, where we can have the interaction between the baby and the caregiver, or the interaction between the baby and his mom. Attention and interaction, it is the state where the baby can have the interaction with the caregiver. And the 5th state is the self-regulatory, where it will help us identifying the development of the baby, where the baby will start changing the position, the hand to mouth, and the grasping, sucking reflex. Now, to know this, we should know about the neurosensory development of our babies that passes through 6 states: the touch, the vestibular for the motion and balance, for the smell, for the taste and gut, the hearing, and finally is the vision. After the sensory, we should know about the motor control, where the process of the brain and spinal cord will coordinate as a one movement for the posture and the movement. And regarding the motor development of our newborn baby, it is a process of change in the motor behavior that occur relatively to be extended over the time, and it results from both the internal and external influences or stimuli, and this will lead to the maturation and growth learning, and it is affected by our environmental condition inside the NICU. So what are the factors that will affect the developmental motor development? It is the quality of motor skills of the preterm babies that will, and this is including the tone, the strength, the endurance, the motor planning, and sensory integration of those preterm babies. So what is motor learning? This is a definition. And what is the motor learning? It is not a one technique. It is a processes that it is developed inside the NICU and will help the preterm to have a relatively permanent change in the skilled motor behavior. What about the sensory motor? We heard the sensory, we tackled the motor. Now, how we will integrate both together? It is the relationship between the nerve and the muscles, and it is the process where both the system will work together and coordinate that overall movement outcome is achieved. And this will develop through life, and it will maturate at the age of 7 years. So what is the three integration sensory parts? It is the stimulus that will, the organ will sense the stimulus. It will reach to the brain where the brain will interpret the stimulus, and from the brain it will analyze which organ or which movement should be relayed the information, and hence the response will happen. This sensory motor development will affect the balance, the right and left handedness, knowing where the body is in the space, and the self-confidence in being control of the body. If it is immature, then it will lead to avoiding in the writing task later on, difficulty with the hands-eye coordination, clumsy, confusion, and difficulty in getting dressed, and difficulty crossing the midline. All this will have an impact on the babies and impact on the families. Impacting the baby, we know that we are dealing with more preterm babies due to the development in the technology now and the medical treatment. As a result, the preterm babies might face a very unnatural environment because they are outside the uterus. And this will lead to both either delayed or altered development of the baby, as obvious in many aspects as we discussed earlier. So how we will provide the individualized developmentally supportive care? By adding this perspective, making a guideline for the unit, utilizing the infant developmental specialist in the partnership. And here comes the role of multidisciplinary team management for those babies. And also we have the assessment and the recommendation, whether they need CAP or the infant developmental specialist. We should have a plan for the light sound activity level and control this to mimic the intrauterine environment. We should have individual individual infant environment that will help the baby resting in the atmosphere, mimicking the intrauterine atmosphere by approaching by using the appropriate pacifier, by appropriate based on the gestational age, and the type and configuration of the bedding and clothing of those babies. Also, we should emphasize on the positioning of the baby, whether to encourage the hand-to-mouth and midline alignment, using the proper nest to provide the security, by giving the feeding when to determine the readiness for the feeding, also the choosing the appropriate nipple or pacifier, and the strategies to be conveyed to the staff and the families as well. Caregiver should have sessions and education that will help in implementing this NIT CAP, education for the families, and the encouraging the kangaroo mother care. And what is the impact on the families? We are having impact on the, we can divide this into 3 stages. The first stage, if the families are having this premature delivery as unexpected, so this is as if they are in roller coaster situation, and they are totally unbalanced, and they are not knowing what is the outcome, and they are not comfortable. If they are expecting this is another point that we should tackle from another point of view, because the parents are already tired, stressed, and they feeling guilty that they are the cause of this premature delivery. The more the birth is, the more the complication for one of the or both of the babies. Another point that we should keep in mind when dealing with such situation, if the mom is a teenager or at risk, then the rate of abuse or neglect might occur, and hence we should involve the social worker. The NICU setting, as all of us knows, is not the best favorable place for the parents to visit, and many parents report that they are missing the interaction between them and their babies. The NICU experience place is a huge strain for the parents as well, and other family members. It is difficult for other family members to visit their relative or their sister or brother inside the unit. There is prolonged hospital stay, and hence one of the parents might lose their job, and this should be kept in consideration because the multiple missing the working time and having to give up the job at a time. So we should have a family support. We should keep in consideration that this mother is more prone for depression and will impact the child development, and insurance will not cover. As a summary, the NIDCAP represents the best evidence NICU practice and the best brain ACRI. All decisions are ultimately directed care decision and impact on the infant and families. We should accept the system change and make the requirement to aim for the best neurodevelopmental care of our preterm babies. Each of us has only one brain for life, and this is what we should aim for our preterm babies. It matters how we use it and how we care for our babies and those of the infant in our unit. These are my references, and at the end I would invite you for the 50 years conference, the 15th International Arab Neonatal Care Conference, that it is held between the 27th and 29th of September in Dubai, inshallah. By this I conclude, and thank you very much.
Thank you, Dr. Khalid, for an excellent talk. Our next speaker needs no introduction. Dr. Junaid Khan, he is the conference co-chair, Director of Medical Education, and a consultant neonatologist at Sheikh Shakhbout Medical City. Please welcome me and join him as we talk about the controversies in enteral nutrition of preterm infants.
Thank you very much. Thank you, everybody. Thanks a lot, the audience, once again. So, since morning we are saying about a lot of things which is taking care of the babies, and Dr. Khalid Atabi set a stage by doing the NIDCAP. So we shouldn't early discharge the baby. We shouldn't delay the discharge. And feeding is one of the things which have a lot of controversies, and I'm going through it. First, I don't have any conflict of interest, but why is talking about preterm enteral nutrition? And the reason is that there is over 200, only in English, articles are published each year. And this is generate many myths and what you call misunderstanding. I'm afraid to say, maybe many of you don't like it, but we do not teach preterm nutrition well. We have to be very careful about that. So look at this, a fact often not realized by many and the paradox. So this is the growth chart, and the preterm babies are the low birth weight, and they are not the full-term baby. They remain at the lower age. So these are the two examples. One is the green and one is the violet color. Both are still remain lower than the full-term babies. So what is the paradox? This is the paradox. The optimum postnatal growth of preterm baby is not known. Therefore, the wisdom of forcing those baby on catch-up growth is questionable, and particularly if it does not improve the outcome or may cause harm. So please, all those in favor of high energy formulas, please take aside, think about it again. It is harmful. Just allow the baby to grow. This is the big paradox we are dealing with. And this is the reality. If you see the data from USA, 50% of them are less than the curve, 31% in the bond, and 27.5% is less than third percentile. Range is about 16 to 63%, which is the higher range. So we have to deal with that. So recent evidence they are giving to give the idea of insulin growth factor 2, but this is the chances of having a lot of postnatal potential of cardiac metabolic disorder later in the life. There's a lot of adverse development, particularly neurological, cardiovascular, bone health, and others of the premature babies. They are all already on risk of that. But our nutrition pattern, our nutrition strategies can make it more worse. The nutrition requirement is just published 2022 as SPAGAN, and you all know it. We just go through very quickly. We don't have to read it. It is all in the internet. Similarly, at the same time, they again revise the energy requirement for growing premature infant, and these are the a snapshot of that, that it is required about 120 kilocalories per kilogram. So this is a long list of controversies. I've tried to go through it, but not all of them, but there's a long list of controversies, but I'll choose the more important one. So first thing, still we are not doing good. What to feed? There is no brainer in it. So everybody agree with that, what to feed? And of course, we have to feed the breast milk, the mother's own milk. If the mother's own milk is not available, then donor milk. And as Quran says, the mother shall give suck to their offspring for 2 whole years, Surah Baqarah. So we have to do that. But why breast milk? If I ask all of you, the most of you answer because of the sepsis, because of IgA, because of the infection. This is the most common answer I get during my rounds and this, but it is more than that. Let's revamp it. The rethinking and the serious rethinking about it. Look at this, the data. 2.7 to 3.3 fold increase in NEC, 1.4 increase in PDA, 2.4 fold increase in ROP. Morbidity index, as you can see there, this is the one, the morbidity index is NEC plus sepsis plus death increased by 40%. So these are the major issues. Asthma, diabetes, eczema later in the life. So if you give every 10 ml of the breast milk, they are reducing 12% of the mortality, 19% reduction in the sepsis and the neck, and the 4% reduction in the ROP. So this is very easy to understand so far, but the life is not that easy. Issue with the breast milk also, and we are talking about the preterm enteral nutrition. The problem is that the preterm baby is not supposed to born. They're supposed to born in the full term. So the milk has the problem. The changing in the milk from the day 1 to the day 3, day 4 of the life, the protein contents of the milk go down, the lipid content of the milk goes down. So we have to think about it. So look at this thing that Educate protein is about 4 to 4.5, as I told you about the Aspigan, and range is 0.7 to 2.4 in the breast milk. So we have to give a fortification for that, because if you don't give the fortification, then the baby will not get the proper nutrition. And there is a big thing. I was involved in that debate. Dr. Nina Moody has some idea that give a lot of amount of breast milk and do not fortify, but it is not buying by many of the things, especially the people in USA. Volume of the mother's milk required is, if you don't fortify, look at the volume is required. For example, for protein, you should give 270 ml per kg per day, which is too much for the very small stomach of the preterm babies. Now, we have to fortify. Now, fortification is not that simple that give 25 ml, give one sachet or something like that. So I will go through it. So why fortification? We already explained to that. The breast milk is not enough for the total the macronutrients and micronutrients. So we have to fortify that. But does fortification real help or not? This is, we have to answer. Data suggests yes. So this is the latest data about from the Cochrane, weight gain, length gain, and head circumference. All are in favor that we have to give the fortification. Now, the current fortifiers, how we do that? The standard fortification, as I said, that 50 ml one sachet or 25 ml one sachet. But problem with this approach, even that the protein requirement is not that optimum. Individualized fortification, which is the adjusted fortification, you measure the BUN, blood urea nitrogen, and see that the protein content is enough or not. Why the protein content? Dr. Khalid mentioned about the brain development. Protein is the main nutrient to develop the brain. So blood urea nitrogen, if it's less than 10, you have to increase the fortification. 10 to 16, same, and more than 16, you have to decrease the fortification. Targeted fortification. This is a very good idea. Dr. David Adamkin from the Central America, and he is doing that he is checking and analyzing the milk every day, because the milk is changing every day, and then fortify accordingly. And the post-discharge fortification I will talk about in the end. Now, there are many types of the fortifier available. Human milk-based, which is very expensive, and the bovine milk-based, then is the multi-nutrients and the single nutrient. We are not using the single nutrient. We are mostly using the multi-nutrients. So that many type of the fortifier we have in the market. One of them, we are using it, so we don't have. Now, what about the advantages of human milk base, which is the dry from the human milk? This is the study done by the Sullivan at 2018, just before the COVID. And he found it out, the NEC, or surgical NEC, is very low in those babies who are getting human milk-based fortifier as compared to those who are getting the normal bovine. But this study is actually funded by that particular company. After that, in 2023, there is another study which showed not that much difference. So you have to see the weight and balance. And, me, Ayman, and Faisal is involved in that to get or not, because there's a lot of cost involvement in that. So we are just holding our horses on that, and then we wait for the DOH decision if the insurance company bear the cost. Another way is the comparison of hydrolysis or the non-hydrolysis fortified. Hydrolysis, not extensively hydrolysis, a partially hydrolyzed fortifier is better, and it is better to on the gut also, and it is, this is a comparison between the human milk fortifier, either highly hydrolyzed or partially hydrolyzed. So if you are partially hydrolyzed or non-hydrolyzed, it is a better way to do it. When to start, this is another debate. So most of you started at 100 ml per kg per day when that feed reach 100 ml. Am I right? Right here. Okay. So this is the thing. We have to start a little bit early, which is about 50 to 80 ml per kg per day. It is the best evidence. I give you the evidence. Incidence is, the evidence level is 5B. The recommendation level is very high. Application time is also, the recommendation is almost B. So we have to start a little bit, about 50 to 80 ml per kg per day. You reach the feed, you should decrease the TPN or parenteral nutrition and fortify the milk. Post-discharge, I will come back, but there's a evidence for that. Feeding strategy. You are starting feed early or delayed? Early? How early? Right away? Yes. So these are the combined studies of 43 studies, more than 6,000 preterm. There is no difference. Please do not afraid of sick babies or this thing. 1 ml milk available, drops of milk available or colostrum, you should start the feed. So the early feeding is the way versus delayed feeding is not a good way. Feeding intolerance, this greenish aspirate or not aspirate, I will come back to that, but it is no difference between early and the late feeding in the feeding intolerance. And these evidences are all very recent, 2022 and 21. Feeding strategies, again, there is a lot of debate about that. How you feel, orogastric tube, nasogastric tube. You are feeding nasogastric tube or orogastric tube? Orogastric tube, okay. And nobody using the transpyloric. There is a increased mortality in transpyloric, but we have to use in one of the baby, which is because of some reason. But anyway, this is not the routine practice, thank God. I don't have a very robust evidence that orogastric is better than nasogastric, but yes, always we try to get the orogastric as the nasogastric tube increase the work of breathing and can injure the nose. How often? So 2 hourly or 3 hourly? Okay, Ayman Rahmani is feeding 3 hourly. He's on dieting, some kind of a diet. So himself is 3 hourly, but I don't know about other people. So that's our policy. We made it, this policy that less than 1,000 gram, we start 2 hourly and then go to Q 3 hourly when it reach 1,500 and so. It is also not that great evidence, but it says it's a, it is better that 2 hourly feeds in a very small babies and 3 hourly feeds in a bigger babies is a fine. These are the combined studies of 6 study and number is quite big, 872. So the clinical benefit and risk of continuous versus intermittent bolus milk feeding could not be reliably discerned, but there was a trend of benefits toward intermittent feeding, which is Q2 hourly or 3 hourly. Then this is a big debate. My previous Al-Rahman nurses sitting here, SSMC nursing sitting there, they don't allow me to increase the feeds. 18 ml versus 30 ml. What we will do? What should I do? Okay. So the thing is that this is a combined studies, 56 studies. Look at the preterm infant, 1,850 infants. As long as you get the higher rate of increase, the length of a stay, which we just discussed, is decreased. The late onset sepsis is decreased, and 7 days versus 10 days, there is no significant difference between NEC or this and that, so don't worry about that. You can easily increase the feed. Khalid just told about the roller coaster ride. The most important thing is in the parents when they are in very, very misery. The day you told them that tomorrow, most probably, your baby going to discharge. So that's the day, and look at the emotions of that. So that's should do that, okay? So this is the thing. If you delay the thing unnecessary, it is going to be not help. So similarly, how to define feeding intolerance. Gastric volume residue, I will talk about this. Abdominal circumference. So those who are sitting far, look at me. I am not checking my abdominal girth. Why you are checking the abdominal girth of very small babies? There is no need for that. Okay, there are many centers still doing the abdominal girth. Look at this, the statement I put, plus minus 3.5 centimeter throughout the day, it can change. 1.5 centimeters increase occurs normally. So there is no advisable to check the abdominal girth routinely. Passing meconium, yes, it helps. If it is not, then you can give some suppository. Gastric residues. All the evidences come against the gastric residue. You have to not to check routinely. But this is the old study, 10 years old. They said gastric residual volume less than 2 ml. For infant, less than 750 and less than 3 ml for more than 750 grams should be considered normal. The color of the residue. Now, how many of you tell your honest opinion, when you get the greenish aspirate, how many of you give it back? Anybody giving back? Very good. Which center you are working? Okay, Tawam, I have my own doubts then. Sorry for him. Excellent practice. Because these greenish aspirate is full of nutrients, it's full of the thing which is what you called it, anti-inflammatory thing. So please always give it back to that, and it is not, harmful. If you check it regularly, then you will say aspirate, and in the night, and Ahmad become very upset in the night, somebody start, septic screen and start antibiotic for no reason. So this is the harm for gastric residual. So evidence for checking gastric residual is limited. I will give you 3 articles just published, routine monitoring in 2023, then does routine monitoring helps, and the latest one is the multi-center blinded randomized trial just 2 months ago in the March is published, and they say there is no difference to check it or not. Now another sensitive thing, PPI, proton pump inhibitor. How many of you are using? I know you are using. If you are not saying you are not using, I will go to ChatGPT and ask that Tawam is using it or not. Okay? So I will ask it. So how many of the PPI you are using it? So it is the practice or exercise in futility. PPI is the acid reflux inhibitor. If you see the babies, they all are the non-acidic reflex. So please do not use the PPI. There's a horrendous side effect on that. Microscopic colitis, dysbiosis, risk of developing allergy, autoimmune disease, chronic use have negative nutritional impact. We don't have to go through all this study, but the answer is there should not be used. So final take for the PPI, do not use it, remove it from your center, and just try anti-reflex. Knit cap. Try your knit cap. Baby will not reflux. Feeding strategies, blood transfusion. I will not talk. The next talk, Professor Hakam Yassin will talk about it, but we are not holding the feeds for the blood transfusion. PDA. We are closing the PDA or not closing the PDA, stopping the PDA. We have in our last session today, we have all these things. They will answer. But you just restrict your thing, but continue the feeding. UAC, obviously, we continue the feeding. Enteral nutrition in terms of congenital heart disease, it is a very, sensitive, stop it, no. We just have a baby with a TGA, more than TGA complex, am I right, Ahmad? And then we continue with the feeding and nothing happened. Baby did well. They did the atrial septostomy in the SKMC. So we are continuing that, yes, you have to restrict because of the risk of cardiac failure. How many of you using probiotics? Or you stop using probiotics? Okay, stop using probiotics. We never start probiotics, am I right, Faisal? Even in Al Raba, we didn't give the probiotics. But there are initial some evidence about the probiotics by use of probiotics is published in 2021, and it said it is not demonstrated any results. And if Mariam is sitting there, I am also using the AI to make up figures. Remember, the Mariam shows the same figure, advantage and disadvantage. So the positive factors and the negative factors, gut dysbiosis. If you see, the negative factors overweigh the positive factors. On top of that, Dr. Hamler is very much into the FDA approvals, and this is the September 23 FDA warning. So it is removed from the US market. Ahmed, am I right? If you just came from there, you removed from the US market, they are not using it. But having said that, probiotic has some effects, okay? It is up to you. You want to take a risk. If it's up to you, what is the incidence of NEC in your department? Growth of late preterm fed infant nutrient-rich formula, again, there saw no difference. So high energy or, to put something, it will not make any difference. But the post-discharge nutrition is very important, and this is by a very latest article by none other than Alan Lucas. So the post-discharge fortification you can use many ways. This is one of these strategies that mother breast milk, and then you give some feeds of post-discharge to maintain it up till 4 to 6 months. It is recommended by the AAP, and we also recommend that when the baby discharged from the hospital, because the fortifier which we are using in the hospitals are not available outside. Last 2-3 slides, feeding strategies, having an enteral feeding strategies, you have to have a protocol. Not all the physicians or seniors and juniors are doing differently. So this is one study that's combined with the 16 meta-analysis. All studies showed that if you have a unit enteral feeding strategies, improved weight gain, reduced length of stay, and improved outcome. And this is, sorry about that, this is another study I want to show, but I don't know how to go back, but anyway. So this is the main of all the curves, barriers and strategies to initiating and advancing early life enteral nutrition. The first thing, fear of NEC. Develop your thing, a protocol, and implement that. And it has to be on evidence base. Dysmotility of the prematurity, yes, it is there, so it is nothing to do with the reflux or to PPI. Early use of suppository you can, and you can decrease the sedative and paralysis. emesis and or abdominal fullness, I told you not to check it. The regurgitation is going to be there, so don't worry about that. High gastric residual, do not check normally. If the baby is really sick and it's really you are worried about this thing, then only check it. Hemodynamic instability, even with the pressors, nowadays if they are not on very high pressures or not very sick, we are using and we are continuing with the feeding. This is one of the protocol. This is the way we are doing it. The only thing which we are not doing, that we are not increasing the what you call the fortification at 50 to 80. Otherwise, we are doing that. So the time is over. Time for conclude this. Preterm babies should be fed early and should be fed, breast milk. So the breast milk and mother's own milk. If the mother's own milk is not available, it should be the donor's milk. And 3 hourly feeds for baby more than 1,000 grams or 1,200 grams, some people said, and 2 hourly fed is less than 1,000 grams. There's a little difference between continuous or intermittent tube feeding, but does not push the baby. Sorry about that. Having feeding strategies help your unit to come out of these controversies, and everybody doing the same things and will affect it. Of course, you have to monitor and to follow your babies. The clinician must seriously consider the multi-system short and long-term implication. As we discussed that, it can have a long-term effect on the babies. So please go back, revise your feeding strategies and remove all those things which we just discussed. Why it is important? Because nutrition is the one thing in the NICU we can do something about, because ventilation, all other things are still, we are struggling with that. Thanks a lot for that.
Thank you, Junaid, for an attempt to address controversies in enteral nutrition. I expect a tough question and answer session shortly to come. Between us and lunch is one more talk. Professor Hakam Yassin. He's a consultant neonatologist and professor of pediatrics at the University of Sharjah. He also serves as the chief medical director at the University Hospital of Sharjah. He's going to talk to us about does blood transfusion increase the risk of NEC? Please join me in welcoming him to the stage, please.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I would like to thank you, Dr. Ahmed, for the introduction. And would like to thank Dr. Junaid and Dr. Ayman for inviting me to this prestigious conference, which I'm proud that I am contributing to this conference from conference number 1, and now we are 13. So, let us start about this question, necrotizing tuberculosis and other factors, and we'll start by this clinical scenario. So this is in 2009, I am mentioning the year, 850-gram babies delivered at 25 weeks. At 3 weeks of age, baby had hemoglobin value of 8. At that time, the baby was on oxygen high flow, 23%. So the baby was transfused 20 ml per kilo of packed RBC. So who agree with this practice to give blood transfusion in baby on ex-preterm baby or preterm still, and he is on oxygen? Or anybody he is against this practice? Okay, there are 2 colleagues that they are against this tracker. Okay, so we'll go to unfortunately, baby developed sign of necrotizing tuberculosis next day with intestinal perforation, followed by a death later on. Parents did a complaint against the hospital, and the court charged the hospital financial compensation for the parents. So there is, of course, uncertainty and there is controversiality with necrotizing tuberculosis and other factors like anemia, blood transfusion, and also, again, feeding practice during blood transfusion. So the objective of this presentation will answer to 3 questions. The first question, does anemia, severe anemia, affect the intestine and increase the risk of necrotizing tuberculosis? This is the first question. The second, blood transfusion and relation between blood transfusion and necrotizing tuberculosis. Does blood transfusion increase the risk of necrotizing tuberculosis? And the third, what is your practice, or what's the feeding during blood transfusion? The role of tissue hypoxia in necrotizing tuberculosis. As you know, the authors that's in favor of anemia that it can cause necrotizing tuberculosis, you know, the hemoglobin is transferring oxygen, and then they mentioned that there will be tissue hypoxia which increase the risk of necrotizing tuberculosis. So in animal studies, it's suggesting that tissue hypoxia is an important risk factor for necrotizing tuberculosis, which have been supported by data from clinical trials. So animal studies showed that severe anemia induced significant increase in intestinal tissue hypoxia that led to macrophage activation and interferon gamma production by tissue macrophage. Taken together, these animal studies shows that severe anemia may drive gut inflammation with impaired intestinal barrier function, and so could have potential role in the pathogenesis of necrotizing enterocolitis. So in this hospital that they give transfusion because in this that they are afraid of the anemia that it will cause necrotizing enterocolitis. The new PROM meta-analysis, as mentioned in the first session, assessed 5 randomized clinical trials, including 2 groups of lower oxygen saturation target, which is below 90, 85 to 89, compared with higher saturation, 91 to 95. And they mentioned that among secondary outcome, infants in the lower saturation target group, below 90%, had an increased risk of death and a higher risk of severe necrotizing enterocolitis. So they mentioned in this that when it is the low saturation low and it was related to the anemia, then it will increase the risk of necrotizing enterocolitis. Now, observational studies have also supported the potential role of more severe anemia in the pathogenesis of gut inflammation, and a multi-center observational cohort study, including around 600 preterm infants, showed that severe anemia in given week, hemoglobin less than 8 grams, was associated with higher rate of necrotizing enterocolitis. So again, this in favor to give transfusion if you reach 8 grams to avoid necrotizing enterocolitis. Similar studies were reported by Singh and colleague in a study of 333 preterm infants with matched control. It was found that with each 1 percentage point decrease in the nadir of hematocrit associated with a 10% increase in the odds of necrotizing enterocolitis. So, whereas there is no consensus with definition of transfusion-associated necrotizing enterocolitis, most studies have characterized the entity as the development of necrotizing with 48 hours followed an blood transfusion. As most infants receiving red blood cells transfusion are anemic, so it's difficult to differentiate the effect of blood transfusion from the effect of degree of anemia, because of both of them, anemia and necrotizing enterocolitis, may affect the percentage of necrotizing enterocolitis. Now, does severe anemia cause gut injuries? So certain authors are trying to answer this question based on the analysis of relatively recent large trial of preterm blood transfusion. See these large trials on preterm blood transfusion. There are 2 studies, new studies, the ETHNO studies and TOP transfusion of preterm trial, and both of them they are published in very important journals, and it's a high number of patients. The main objective of these trials was to find out whether low threshold of red blood transfusion would be associated with more deaths / neurodevelopment impairment compared with liberal. Now, let us go to the numbers, because then we will see our colleague that he gave the transfusion with it, whether he is correct or not. The transfusion of preterm baby, the TOP trial, was multi-center randomized trial in 41 neonatal study. It means that it's a very huge number with 1,824 infants. When it was compared between the conservative versus liberal blood transfusion guidelines, the trial found no significant difference in the risk of death or neurodevelopment impairment at 22-26 months. So the other one is ETNO. Again, it was at the same time, in the same perspective, and it also large randomized study, European study with 1,013 infants, which found also no difference between the restricted group versus liberal. And so the ETNO also trial finding was consistent with top trial, no effect. Go to the numbers. This is what I want to show you. This very, very important table, and it can help also in your practice. So go to the same. So there, the ETNO and trial and the top trial, they are both similar in their. So there is both of them. This not showing. So they have oxygen. Both of them. They have oxygen group with oxygen or with respiratory support, and go back down also. The other group, they are not on oxygen. So on oxygen, if we go to our example, the 28 weeks, he is 3 weeks old with oxygen. Both of them, they will give transfusion. So his practice, the colleague that he gave blood transfusion is okay. 8 hemoglobin, 8 gram hemoglobin, and at 3 weeks with oxygen, I think most of us will give. I will give blood transfusion, and both of these trials they give blood transfusion. So here in 3 weeks and oxygen in ETNO, they are giving in the restrictive group, they are giving 9 gram, and in the restrictive group in the top, they are giving around 8 gram. They are giving transfusion. Now go down. If you have a baby, also he has a 3 weeks age, but not on oxygen, or not on any support then they are going to give blood transfusion at around 7, both of them, if they're restrictive. And personally, we are following the restrictive policy and give blood transfusion. If the baby is not on oxygen, we are reaching 7 gram before giving but other liberal, they are giving 9 gram blood transfusion. Now, in all of the trials, NEC was assessed as a secondary outcome, and there were no difference in the incidence of necrotizing tuberculosis when comparing higher versus lower transfusion threshold arm. Meta-analysis of these 2 trials, in addition to other smaller trials, have not found a difference in the risk of necrotizing tuberculosis between the restrictive and the liberal protocol. So the conclusion of this part, that based on the above, the results support the safety of tolerance of anemia using a lower transfusion threshold as hemoglobin 8.5 to 9 gram for babies with oxygen at 3 weeks of age, and around 7 gram at around 3 weeks for the same babies. So we could answer the first question that there is no evidence that anemia with low hemoglobin 7 to 8 would cause intestinal injuries and NEC in preterm infants. This is the first question that we answered about the anemia, related anemia with necrotizing tuberculosis. Now we'll move to the second question about blood transfusion and necrotizing tuberculosis. So does blood transfusion cause neck or gut injuries? Again, animal studies, there was demonstrated that RBC transfusion triggered gut injury in anemia mouses that received RBC transfusion. When RBC were transfused in the absence of anemia, there was no evidence of gut injury. Again, we will not give, of course, this is an animal, but in vivo, in right, and our practice will not give blood transfusion to the baby that is not anemic. Additionally, mouse that received multiple RBC transfusion sustained more severe, so if you give more blood transfusion numbers, so it will also get more injuries for animals again. Again, these data support the possibility that anemia in animals may prime the gut for macrophage-mediated inflammation with a subsequent red blood cells transfusion adding a second inflammatory insult. Observational study indirectly support the role of antecedent anemia prior to blood transfusion in the potential risk of NEC. Now, meta-analysis in 2012 of 12 observational studies, largely case control by Mohammed and Shah, shown an association between exposure to blood transfusion and higher risk of necrotizing tuberculosis. And this is involved. However, since that meta-analysis, there have been additional studies with conflicting findings. Again, colleagues and Hay and colleagues found that overall certainty of evidence association between NEC and blood transfusion was low, with inconsistency, consistency, and significant heterogeneity across studies. This raised the possibility that true association may not exist. Ray and colleagues performed a separate systemic review and meta-analysis of observational studies comparing the risk of developing NEC in infants who were received a recent RBC transfusion within 48 hours to those who were not received RBC transfusion prior to the diagnosis. And here they found that a statistically significant reduction in AC. And here they show that blood transfusion is protecting against necrotizing tuberculosis. You see the conflicting result between there is risk of necrotizing and here even protective. A more recent meta-analysis by Garg and colleagues of 17 observational studies, they found no significant association between a red blood cells transfusion and the risk of necrotizing. So in conclusion, this is the second question that we will answer. There is conflicting evidence about the role of blood transfusion in causing necrotizing enterocolitis in clinical studies. Meanwhile, no association hypothesis has longer evidence. There is conflicting, but no association is stronger than blood transfusion would cause necrotizing. So we finished two questions about necrotizing and anemia and necrotizing and blood transfusion. And the third question here, the last question in the presentation, should we withhold feeding during blood transfusion? Who is withholding feeding? I know Dr. Junaid is against that. He mentioned that he is not mentioned one study. Anyway, it's conflicting. We'll show the conflict. So in our, of course, unit, we are withholding the blood transfusion. So based on the rationale that NEC risk may be increased following red blood transfusion, some observational studies have evaluated if withholding feeding around RBC transfusion may reduce necrotizing tuberculosis. Of 10 studies examined, only one study reported a statistically significant decrease in the incidence of NEC after withholding feeds during transfusion. So 9, they did not show that it will decrease necrotizing. One, it found that it decreased necrotizing tuberculosis when you hold the feeding. Other studies did report a decrease in NEC rates after the implementation of feeding protocol, but these were not statistically significant. However, some of these studies had small sample size with a lot of confounder factors. Meta-analysis including, this is also again newer, more recent in 2017, meta-analysis including 7 studies with around 7,500 infants that examined the association between withholding of feeding and NIC following RBC transfusion. The study reported that withholding of feeding during RBC transfusion was associated with a lower risk of necrotizing, and it's around 50% is protecting. This study showed moderate grade certainty of evidence. As part of multi-center quality, again, this is another study, quality improvement initiated in 8 NICU, Talavera et al. Implemented withholding of feeding during transfusion coupled with standardized human milk feeding. The study reported a decrease in NIC evidence from 8% to 3%, which is significant. So Cochrane meta-analysis study concluded that randomized controlled trial evidence is insufficient to show whether stopping feed has an effect on the incidence of subsequent NIC. So Cochrane did not show, of course, that there's significant decrease. Now, this is very important for our colleagues, that there is a large ongoing randomized controlled trial. The WheAT trials are 2 similar multi-center randomized trials, with one being conducted in Australia and in New Zealand, and the other in Canada and UK, based on the design of a pilot trial in the UK. It will be some time before data could possibly become available in 2025, and perhaps next year will be the result, because this is a very controlled study and will answer perhaps the question to stop feeding or not to stop feeding during blood transfusion. So withholding of feed and NIC following RBC transfusion until more data are available. Our unit, of course, as I mentioned, that we stop feeding during transfusion. So we'll go to the conclusion. Severe anemia and RBC transfusion are associated with gut inflammation and injury in animals, most of these in animals. However, there is uncertainty about the role of anemia in the pathogenesis of NIC in the clinical reports, given the result of recent randomized trial, TOP and ETHNO studies of lower versus high RBC transfusion threshold. It appears that the lower hemoglobin threshold studies in the trial are safe with regard to the risk of necrotizing enterocolitis. There are conflicting evidence about the role of blood transfusion in causing necrotizing enterocolitis, but no association hypothesis has stronger evidence that there is no effect, the blood transfusion, no effect in increasing the risk of necrotizing enterocolitis. As low infant hemoglobin is safe, in our neonatal unit, we are following the restrictive guidelines policy, as I mentioned. Observational studies have shown that withholding feeding during RBC transfusion may lower the risk of NIC. Ongoing large trial, the WheAT trial result would be in 2025, may provide more certainty regarding the practice of feeding during blood transfusion. Thank you.
Next, I would like to invite the speakers to the stage for our next Q&A session. Dr. Khalid, the stage, please. Go ahead, please.
Oh, excellent.
Not working? Is the mic working?
Yeah, it's okay. Thank you very much for a very nice, enlightened session.
Can you introduce yourself? Oh, I know, just kidding.
Hello, can you hear me now?
Yeah,
Yes.
Dr. Junaid, I have a question
Yeah, sure.
from you. You covered all the topics, but there are 2-3 controversies what I noticed during my clinical practice. First thing is that, like a normal delivered babies, they do have a little bit of higher lactate sometimes, that like 3 to 5, which stays for
Who
24.
asked you to check the lactate in a normal delivery?
Sorry?
Who asked you to check the lactate in a normal delivery?
That is a problem in our unit, in our hospital, they check it.
Hence, I prove my case.
So anyhow, the question is that if lactate is 3 to 5, baby is clinically well, blood pressure is good, urine output is good, but still some of my colleagues, they stop the feeding and they hold the
Oh,
feeding.
Are they sitting here?
I cannot name them.
I mean, come on. You are
Yes.
saying blood pressure is okay, kid is fine, lactate is 3.5. So we have to go to the pathophysiology, why the lactate is high, okay? And why initially the baby got in the, especially the vaginal delivery, how much pressure he got, and the
Apgars are good, everything is good, but lactate is slightly higher.
So if you are checking the lactate, I will, report to Daman.
Okay, second question. Second question.
Yeah, second
IUGR babies. IUGR babies, and there is also a debate, although there are a lot of,
What you said?
IUGR.
IUGR?
yeah, small for gestational age or intrauterine growth
Yes.
retarded babies.
Yeah.
It is a practice clinically that we again follow the lactate and we say, okay, lactate is 3 and above, baby is clinically well, but we will not start feeding. So what?
I asked my other colleagues to answer this because we are not having this practice. Unless and until we have to check the blood gas for some reason, we will check it and then we are not stop the feeds, okay? So Khalid or Dr. Professor Hakam, you can answer about the lactate and well baby.
Well, in my practice, if intrauterine
Intrauterine growth retardation.
growth restriction or retardation, if this is chronic during the
Chronic hypoxia,
not acute.
yeah.
If it's associated with a significant fetal distress,
That's
and
a
then lactic acid was increased, yes, I will hold on the feeding. But if you see that the baby is doing fine, good Apgar, no fetal distress, I will not stop feeding.
What is your cutoff for the feed? Like if the lactate is below 3 or above 3 or what is?
Wallahi, as mentioned by Dr. Jain, I don't do it as a routine. But if there is a fetal distress and low Apgar, yes, I will do it.
Okay.
One question to Dr. Hakim. What about holding the feed in term babies if they need a blood transfusion?
Yeah, it's good. Well, in general, this a policy for all.
Okay.
That policy of the unit, I'm saying. I'm not saying that it is the correct because we will wait for the 2025 to answer this question. But in our unit, blood transfusion as a policy, nurses, they know that during blood transfusion, 2 hours before and during and 2 hours after, we stop feeding,
Even in term infants?
Yes.
Okay, thank you.
which is very rare to give blood transfusion in term baby.
Victoria, go ahead.
Assalamu alaikum. Dr. Lazir from Al Qasimi EHS. Thanks a lot for the nice talk since the morning. My question again to Dr. Junaid.
Yeah.
You have mentioned regarding the timing of the feed, Q2 or Q3 hourly, according to the weight. What about if I have a 33, 34 weeker, but a severe IUGR whose weight is less than 1,000? Will there be any role for the gestational age, or you still will go with the weight?
So that baby is tolerating feed Q3 hourly?
Sorry?
If that baby delivered to you, and you are taking care, you start Q3, they are tolerating feed and everything is okay?
Yes.
So continue Q3 hourly.
Can I add this?
Please.
See, then I come back to, I made this thing very simple, okay? And the thing is that if you conclude, if you do all these things that IUGR, you are checking lactate, and if you are holding the feed, we will not go through anywhere. Just see the baby. Clinical examination is the most important and more higher sensitivity and negative predictive value. If the baby is fine, you do whatever the baby likes.
So yeah, putting the cut line for the weight as 1 kg and above, 1
Yes,
kg and
this
below.
is as per data they have.
Okay.
So if it is less than, then mostly we are doing Q2 hour. But let's say the baby is not tolerating well, we shift back a bigger baby to Q2 hourly. There is no harm in it. And I am 100% agree with Faisal, we are doing the same thing, that we shift to Q2 hourly, there is no harm. sometimes you have a very high resistance hypoglycemia of a GDM baby, mother of GDM baby.
Yes.
So the thing is that we shift to Q2 hourly is a full-term baby. So
Correct.
that's how it is.
Tamam. One more
If
question,
I add,
please.
if I add one about, and our practice is what mentioned like Dr. Junaid.
Yeah.
If below 1,500, we are giving every 2 hours. If more, then we give 3 hours. What is the concept behind that? The concept when the baby is inside the small, the stomach also is small. So the reflux, they says like series, like the small size of. They found that the growing of stomach increasing with the size. So the risk of reflux will be less.
Yes.
But it is there, it's not evidence-based, all this. This is by practice that we are doing.
Tamam.
Do
If
two more
Dr. Ayman
questions.
allow
Yeah.
me, one more question, please. Regarding the use of the PPI, it's always debatable between us neonatologists and the pediatric surgeons, especially when there is a GI
Sorry?
pediatric surgeon, use of the PPIs.
Pediatric surgeon has nothing to do with the neonatology. I am sorry to say
But
that.
after the surgery, they have put their hands, so they have to continue and recommend using
After
the
the
PPIs.
surgery, I'm not talking about after the surgery. After the surgery is totally different. I'm talking about those babies who have some reflux, have some
خلاص.
regurgitation.
You answered me.
Thank you.
One more question. Go ahead.
Thank you very much. So my question about the hold the feeding or not to hold the feeding, Dr. Hakam. I think every baby is different. Like if it's the degree of anemia, how much blood you're gonna give, and what's the clinical situation of the baby. So first, I noticed that when the case that you present is that the amount of blood you give is 20 per kilo, which is not really our practice. Our practice is 10 to 15 per kilo. So can you just comment on this? And the other thing I would like to maybe suggest that, how about using NIRS to check for the mixed venous oxygenation during the transfusion, to close that topic for us, if this blood transfusion affecting your gut perfusion, and decide if you wanted to. Dr. Junaid is like blindly is not holding the feeding. Now we hold the feeding in our practice because you said the jury is still out about what to do. I think 4 hours of holding the feeding is not going to hurt the baby, but if you have a neck, you're going to set the baby back weeks in the feeding. So that's why we're holding the feeding. But how about we'll try to do start utilizing NIRS during transfusion to see what the gut perfusion is. So can you just comment on these two questions, the amount of blood and the utilizing NIRS during transfusion?
Yeah, NIRS we are not practicing it. Yeah, you can answer. Yeah.
Okay, for about the NIRS, we are used in Al-Raba, and now we order in our SSMC also for things. And we used to measure the feeding intolerance and this thing. We never found anything. Long time back, if you remember, Ayman, we also hold the feed at that time when it is initially come. But after that, when we found the baby is fine, the 4 hours feed, why to,
But I think you have to be individualized because not really all the babies the same.
Yeah.
So some babies, maybe you have severe anemia, they're premature babies. I would just hold the feeding for 4 hours.
Again, you have to be very careful because one NIRS, what you call probe, is cost about 800 dirhams. So you cannot put on all the babies if you are a busy unit with very premature babies. So you have to have a selective babies. So you have to take other questions.
Can you just comment on the amount of the
amount, yes. The amount usually is 15 to 20. In our practice, we are giving for the preterm higher, like more than 1 kilo 500 to full term 15, and extreme preterm maybe we are giving 20 ml per kilo. I am not aware about fixed number, but 15 to 20.
Well, what we do is 10 to 15 if you have no bleeding, but if you have bleeding, you go with 20. So, but
I'm not speaking about bleeding. I'm speaking in general.
No obvious bleeding. Okay, thank you.
Thank you.
We will conclude our session. We're going to go for a break for lunch.
Yeah, for 1 hour.
Yeah, for 1 hour. So we'll be back at 2:15.
Oh, One
you, everybody.
question he has. Yes, go ahead, Muhammad Ali.
Okay. Hi, everyone. My name is Dr. Ali. I'm a consultant neonatologist at Danatul Imarat Hospital. It's more like a comment and just to provoke the thought of the audience than a question, mainly for Dr. Hakam. The scenario you gave for the baby with a hemoglobin of 80 and transfused, again, it's coming back to point from Dr. Ayman as well. Like, we need to individualize the care of the baby. For example, if it's a 24-weeker who is 3 weeks old, I do not expect that baby to be without respiratory support at 27 weeks. And I also, in my view, a 21% oxygen is not different to 23% oxygen. So by just looking at those two papers which you presented, which clearly say if your hemoglobin is less than 83 without respiratory support, then
Can you please keep
everyone
it down?
will just go towards the transfusion. So it's an overall picture. In your case, as you clinically explained, the baby had a hemoglobin of 80, but clinically stable, with no issues about perfusion or blood pressure. So hence, I wouldn't transfuse that baby. So it's just to think about not just to use that guidance for everyone to just pick up that number, because again, in my view, 81 hemoglobin is not different to 83. And FiO2 of 21% is not different to 23. So I
It's
just...
a very long question, but anyway, if you get it, then answer because of the timing.
Yeah. Our practice is going with the two very big trials with ETNO and ROP studies. So both of them, some of them, they are giving 9 gram even with oxygen. If you go to the slides that I mentioned. And the other one, it's 8.5, they give transfusion. In the restricted policy. In the liberal, they are giving 10. So I don't know if you are practicing this previously, the previous guidelines, they give blood transfusion for preterm infant between 8 to 10, if there is oxygen support, if there is not in gaining weight, if there is symptoms like apnea or tachycardia.
No, I totally agree. Like these are when we will all transfuse.
We can do it after that for the time.
Yeah, great.
All
Thank
right.
you, everyone.
Thank you, everybody. All right.
Ayman.
Wait for the
Dr. Ayman Rahman, do you want to come up, please? Okay, he's coming up. He's coming up. All right. Oh, shahada.
Thank you very much. That will conclude our session for the pre-lunch. So we'd like to recognize the efforts of our moderator and the speakers. So the first certificate we're going to give to Dr. Ahmed Mazami for his effort in the moderating this session. Thank you. Can we go?
What? Well, just put it here.
Now we...
Do you want to use the...
yeah,
you can go ahead. No. You do it. You're the boss. Professor Hakim Yassin for joining us today. The next is Dr. Junaid Khan. It's okay, we'll give it next. And then the last one, there's one more. One more.
That's it.
That's it. And then one for Dr. Khalid Atawi.
And for the remaining members, lunch is being served. We'll continue after the lunch. Speakers and moderators, lunch will be served at Dana Meeting Room and delegates at Sahar Restaurant. Enjoy your lunch break.